السلام عليكم. صف خامس، يا رب تكونون بخير. Our lecture today is about the eyelid. We will talk about the most common abnormalities or diseases involving the eyelid. First, we'll talk about simple anatomy of the eyelid. As you see in this picture of the eyelid, we have to know that the upper and lower eyelids usually divided into two lamellae, anterior lamellae and posterior lamellae. The anterior lamellae composed of the skin and the palpebral part of the orbicularis oculi muscle, while the posterior lamellae composed of the tarsal plate and conjunctiva, which is the palpebral conjunctiva. You have to know that the skin of the eyelid is the thinnest skin in the body and it has no subcutaneous fat. The tarsal plate is about 1 millimeter thickness, contains 20 to 30 modified sebaceous glands, which is the meibomian glands that secrete the lipid layer of the tear film. The conjunctiva, which is the palpebral conjunctiva, it is non-keratinized squamous epithelium containing goblet cell. The upper lid retractors involve the levator palpebrae superioris, supplied by the 7th cranial nerve, and also the molar muscle, which has a sympathetic nerve supply, while the lower lid retractors, it is more rudimentary. Blepharitis, which means inflammation of the lid margin. Blepharitis may be anterior blepharitis or posterior blepharitis. The anterior blepharitis involving the area around the eyelashes, while the posterior blepharitis involving the area of the lid margin around the meibomian gland orifice. The chronic anterior blepharitis is a very common cause of ocular discomfort and irritation. Involvement is usually bilateral and symmetrical. Blepharitis may be divided into anterior posterior, as I said. There may be a considerable overlap between them. There is a poor correlation between the symptoms and signs. The anterior blepharitis, which is involving the area around the bases of the eyelashes, may be staphylococcal or seborrheic, while the chronic posterior blepharitis, it is caused by meibomian gland dysfunction and alteration in the meibomian gland secretions. Bacterial lipases may result in the formation of free fatty acids. This increases the melting point of meibomian gland, preventing its expression from the glands, contributing to ocular surface irritation and possibly enabling the growth of staph aureus. Loss of tear film, phospholipids that act as a surfactant result in increased tear evaporation and osmolarity and unstable tear film. Symptoms of patients with blepharitis. It does not provide a reliable clue to the type of blepharitis and are caused by disruption of the normal ocular surface function and reduction in the tear stability. Because of poor correlation between the severity of symptoms and clinical signs, it can be difficult to objectively assess the benefit of treatment. Usually the patient may complain of burning, grittiness, mild photophobia, encrustation, and redness of the lid margin, with remissions and exacerbations are characteristic. Symptoms are usually worse in the morning, although in patients with associated dry eye, they may increase during the day. The signs of patients with anterior blepharitis. Usually patients with staphylococcal blepharitis, on examination, we will see hard scales as we see in the first photos in the upper part of the slide. We see hard scales and crustation, mainly located around the bases of the eyelashes. Also in the figure down, you see the scales with the eyelashes. while in patients with seborrheic blepharitis, there is a hyperemia and greasy anterior lid margin on examination with a sticking together of lashes. Here, the scales are not dry as we see in the staphylococcal blepharitis. In seborrheic blepharitis, the scales are soft, as in the photo, the lower photo, the third photo in the lower part of the slide. The scales are soft and located anywhere on the lid margin and lashes. While those patients with posterior blepharitis on examination, as you see in these photos, excessive and abnormal meibomian gland secretion will appear as a capping of meibomian gland orifice with oil globules, bouting, recession, or plugging of meibomian gland orifice, hyperemia and telangiectasia of the posterior lid margin. In the lower part, or the third photo in the lower part of the slide, pressure on the lid margin results in expression of meibomian fluid or meibomian secretions that may be turbid or toothpaste-like. The tear film usually is oily and foamy, and frothy may accumulate on the lid margins or inner canthi. How to treat patients with blepharitis? We have main 4 points or main 4 measures. The first is lid hygiene, then the antibiotic therapy. The third one is weak topical steroid. The fourth is tear substitute. Regarding the point number 1, which is the lid hygiene, a warm compress is applied for several minutes so to soften the crustacean and the bases of the lashes. Lid cleaning to mechanically remove the crustacean involving scraping the lid margin once or twice daily with a cotton pod dipped in a diluted baby shampoo or sodium bicarbonate. Commercially produced soap alcohol impregnated pad for lid scrub may be helpful. The eyelid also should be cleaned with a diluted baby shampoo when washing the hair. Gradually, the lid hygiene can be performed less frequently as the condition is brought under control, but blepharitis often recur if it is stopped completely. I have to mention that the permanent cure is unlikely for blepharitis, but control of symptoms is usually possible. The second point is the antibiotic. We use topical and systemic antibiotic. Topical antibiotic like fusidic acid, chloramphenicol, used to treat acute folliculitis, but it is of a limited value in long-standing cases. Following, of course, the lid hygiene. The ointment should be rubbed onto the anterior lid margin with a cotton bud or clean finger. Systemic treatment like oral azithromycin may be helpful to control the ulcerative lid margin disease. Systemic tetracycline in posterior blepharitis is the mainstay when contraindicated, but it is contraindicated in children and pregnancy. We use erythromycin. We use, in the third point, use weak topical steroid such as fluoromethiolone for 1 week. It is useful in patients with severe papillary conjunctivitis or flactinulosis. The fourth point, which is the tear substitute, are required for associated tear film stability and dry eye. Example of a benign nodules or cyst, we'll talk about the chalazion, which is a meibomian gland cyst. It is a chronic sterile granulomatous inflammatory lesion caused by retained sebaceous secretion leaking from the meibomian or other sebaceous gland into the adjacent stroma. When chalazion is secondary infected, it is referred to as an internal hardiolum. On histology, it shows a lipogranulomatous inflammatory reaction containing epithelioid, histiocyte, multinucleated giant cells, and plasma cells. Usually, the presentation of patients with chalazion is at any age, with a gradually enlarging, painless nodule. Very occasionally, a large upper lid chalazion may press on the cornea, induce stigmatism, and cause blurred vision. On the slide, we see the histology of the chalazion material. and see the lid nodule, painless nodule, not red as you see. When the lid everted, is very clear. The chalazion from the inside of the lid is very apparent. The signs of the nodule usually it is appear within the tarsal plate, and it may be tender if it is inflamed. Usually it is painless. Eversion of the lid may show the associated polypoidal granuloma if the lesion has ruptured through the tarsal plate. Patients with meibomian gland disease or rosacea are at increased risk of chalazion formation, which may be multiple, as you see in this patient, and recurrent. In the lower photo, when the lid is everted and the chalazion is fixated by an instrument called the chalazion clamp here to localize the chalazion, to do the surgery, as we talk now about the treatment. Treatment of chalazion may be not required because at least 1/3 of chalazion resolve spontaneously, and internal hardyolum may discharge and disappear. Persistent lesion may be treated as follows. Maybe conservative treatment, helpful in the treatment of chalazion by using warm compresses, cleaning the lid margin, using topical antibiotic, and massaging of the area of chalazion to induce the chalazion material to be expressed out of its opening. The other choice is surgery. The eyelid is everted, as we see in the slide before this one. It's everted with a special chalazion clamp. The cyst is incised vertically and its content curated through the tarsal plates. The third choice is the steroid injection into the lesion. Is it preferable if the lesion is very close to the lacrimal punctum because of the risk of surgical drainage. So to avoid damage to the puncti, or it is very near to the lid margin, to avoid damage by the incision and surgery, we can use the steroid injection. Sometimes systemic tetracycline may be required as a prophylaxis in patients with recurrent chalazion, particularly if associated with acne rosacea. Regarding the bacterial infection of the eyelid, we'll talk about what is called an external hardyolum, or it is the stye. It is an acute staphylococcal abscess of the lash follicle and its associated gland of size. It is more common in children and young adults. As you see here in the photo, a tender swelling in the eyelid margin pointing anteriorly through the skin, usually with a lash as at its apex. Multiple lesions may be present, and occasionally abscesses may involve the entire lid margin. Those patients with an stye infection or external hardyolum, usually the treatment involves topical antibiotic, hot compresses. Sometimes we need to epilate the lashes at the point of the abscess. It may resolve the infection and the abscess itself. Viral infection of the eyelid. We'll give an example here in this lecture about molluscum contagiosum infection and herpes zoster ophthalmicus. Regarding the molluscum contagiosum, it is a skin infection caused by human-specific double-stranded DNA pox virus, typically affect otherwise healthy children, with a peak incidence between 2 and 4 years of age. Transmission is by contact and subsequently by auto-inoculation. Usually the patient may be presented with a single or multiple pale, waxy, umbilicated nodule, as you see in these photos. White cheesy material consisting of infected degenerated cells can be expressed from the lesion. Lesions on the lid margin may shed virus into the tear film and give rise to secondary ipsilateral chronic follicular conjunctivitis. So it's very important to examine the lid margin carefully to exclude the presence of molluscum lesion at the lid margin with patient with viral conjunctivitis. Regarding the treatment, spontaneous resolution may usually occur within a few months, so treatment may not be necessary, particularly in children, unless complications like patients with significant secondary conjunctivitis are problematic. Here we have the choices to remove the lesion by shave excision, cauterization, pulse dye laser, and others. Also, patients with multiple lesions maybe need to surgically remove these lesions. Other viral infection of the eyelid is herpes zoster ophthalmicus. Herpes zoster ophthalmicus, it is a common unilateral infection caused by varicella zoster infection that affect the ophthalmic division of trigeminal nerve, affect usually patients with old age, especially patients with immune compromise system, like patients with diabetes, patients with history of chemotherapy, radiotherapy, on steroid use. Presentation is with pain and the distribution of the first division of the trigeminal nerve, with the appearance of a maculopapular rash on the forehead, along the distribution of the ophthalmic division of the trigeminal nerve, progression through vesicle, then into pustule, then crustation. Miscellaneous benign tumor of the eyelid, we'll talk about first capillary hemangioma, then cavernous hemangioma. Capillary hemangioma, which is known as called strawberry navels, it is although rare, it is one of the most common tumors of infancy and present shortly after birth. The female to male ratio is 3:1. Eyelid hemangiomas have a predilection for the upper lid and may have an orbital extension. Occasionally, the lesion may also involve the skin of the face, and some patients have a strawberry navel on other parts of the body. It is important to be aware of the association between multiple cutaneous lesions and visceral hemangiomas. The size, as you see here in the photo, it is a unilateral, raised, bright red lesion, which blanches on pressure and may swell on crying and straining. A large lesion on the upper lid may cause mechanical ptosis, as you see in the third photo in the lower part of the slide. The treatment options of patients with strawberry navels, we have the option of laser ablation for a small lesion, may need use of intralesional steroid injection or systemic steroid, or sometimes surgical debulking by cutting cautery. Cavernous hemangioma of the lid, or what is called the port wine stain. It is called also nevus inflammus or cavernous hemangioma. It is rare congenital subcutaneous lesion consisting of a large ectatic vessels of varying caliber. It is most frequently occur on the face and is usually unilateral and segmental, but occasionally may be bilateral. Some patients have associated Sturge-Weber syndrome. The patients present with a sharply demarcated, soft pink patch which does not blanch with pressure. This differs from the capillary hemangioma. With the age, the lesion does not grow, but it darkens to red or purple. The overlying skin may become hypertrophied, coarse, nodular, and friable, and may bleed or become infected. It's very apparent in these photos. Treatment with laser is undertaken during early life. It is effective in decreasing the amount of skin discoloration in relatively flat or mildly hypertrophic lesion. Photodynamic therapy may also be useful for resistant cases. Now we'll talk about abnormalities or disorders of the eyelashes. First, we'll talk about simple anatomy. The lashes or the cilia of the eyelid are slightly more numerous in the upper lid, about 100 than in the lower lid. The lash roots lie against the anterior surface of the tarsus. The cilia or the eyelashes pass between the orbicularis oculi muscle and the muscle of rheolin, exiting the skin at the anterior lid margin and curve away from the globe. Scarring of the tarsal plate and conjunctiva can alter their position and direction. Following intense inflammation, for example, the lashes may grow abnormally from a meibomian gland opening. Usually it is from the anterior margin, but after the scarring of conjunctiva and tarsus, it may grow from opening of meibomian gland. In this condition, it is called distichiasis, which again, it means arising of the eyelashes from abnormal sites, for example, from the opening of meibomian gland. We'll talk first about trichiasis. What do I mean by trichiasis? Trichiasis is a very common acquired condition which may occur in isolation or as a result of a scarring of the lid margin secondary to chronic blepharitis, herpes zoster ophthalmicus. Trichiasis should not be mistaken for pseudotrichiasis, secondary to entropion. We'll take entropion later in this lecture. When in entropion, when in some cases there is interning of the eyelid, may be intermittent, and the condition may be mistaken for true trichiasis and inappropriately treated. So, in trichiasis, what will we see on examination? It's characterized by posterior misdirection of the eyelashes arising from normal site. So there's misdirection of the lashes which is arising from the normal site of origin. Trauma, of course, when the eyelashes is directly into the eye, there's a trauma to the corneal epithelium, may result to punctate corneal erosions with ocular irritation that worsened by blinking. Corneal ulceration and bonus formation may occur in severe long-standing cases. It's very clear here in the photos, the direction of the eyelashes. See in A, there's a few number of lashes directed to the globe. In the second photo B, more number of lashes directed to the cornea, as you see, to the inside of the eye, not to the away from the globe. The treatment options in patients with trichiasis. First, ablation with a forceps is simple and effective, but recurrence within 4 to 6 weeks are almost inevitable. Number 2, electrolysis is useful for a few isolated lashes. 3, cryotherapy, as you see in these photos. The C photo, now the patient is undergoing cryotherapy. This is very effective in eliminating profuse lashes. Number D, the photo with the letter D here, patient undergone the fourth choice of treatment, which is the argon laser ablation. It is also useful for a few scattered lashes. The last choice of treatment is surgery by full thickness wedge resection or anterior lamellar rotation excision. This is also useful for a localized crop of lashes resistant to other methods of treatment. Other abnormality of the eyelid is ptosis. Normally, the upper eyelid covers the limbus about 2 mm. Ptosis is an abnormally low position of the upper lid, which may be congenital or acquired. As you see in this photo of this child, we see that the left eye with the upper lid is drooping downward. This is called ptosis. Here we have multiple causes of ptosis. We have the neurogenic ptosis, myogenic ptosis, aponeurotic ptosis, and mechanical ptosis. The neurogenic ptosis caused by innervational abnormality or innervational defect such as third nerve paresis and Horner syndrome. Myogenic ptosis caused by myopathy of the levator muscle itself, muscle dystrophy, like in congenital ptosis, or impairment of the transmission of the impulses at the neuromuscular junction, like in neuromyopathic disorders. Acquired myogenic ptosis occur in myasthenia gravis, myotonic dystrophy, and progressive external ophthalmoplegia. The third type, which is the aponeurotic or involutional ptosis, caused by a defect in the levator aponeurosis, stretching or dehiscence with age or surgical damage. The fourth type is mechanical ptosis, is caused by gravitational effect of a mass or by scarring. For example, for a mass in the upper lid, pressing the lid, making the lid heavy and dropping of the upper lid, causing mechanical ptosis. Usual treatment of ptosis is by surgery. We'll talk about the other abnormality of the lid, which is the entropion. Entropion means inward turning of the lid margin toward the globe. As you see here in the photo, the lid is inverted toward the globe, inward returning of the lid, causing even the lashes to be directed to the globe and with touch with the globe. Here, this lashes position, it is not trichiasis as we discussed before. Here, it is pseudotrichiasis. Pseudotrichiasis. Okay. Entropion, as I said, it is inward turning of lid margin toward the globe. We have three types: involutional entropion, cicatricial entropion, and congenital entropion. The involutional or senile entropion is usually more on the lower lid. It occurs with age, with the weakness and that occur with aging. Usually when the lid is turning, there's inward turning of the lid, there will be, as you see here in the photo, there's a pseudotrichiasis causing corneal erosions, ulceration, and pannus formation. The second type of entropion is the cicatricial entropion that results from scarring or severe scarring of the palpebral conjunctiva, like chemical injury, severe scarring disease of the conjunctiva. This results in a pulse of the lid margin seen in trachoma, trauma, chemical injuries, cicatrizing conjunctivitis. The third type of entropion, which is the congenital, it is very rare. Treatment of entropion is with surgical correction. Ectropion. Ectropion means outward turning of the lid margin away from the globe. Also, we have 5 types here. We have involutional ectropion, cicatricial ectropion, paralytic ectropion, mechanical, and congenital ectropion. Involutional ectropion affects the lower lid in elderly patients due to horizontal lid laxity, medial and lateral canthal tendon laxity and weakness that occur due to age. When the lid is everted outward, there's an ectropion. There's defect in the drainage of the tear film to the puncti because of malpositioning of the puncti. So there's an epiphora, watering of the eye, chronic conjunctival inflammation, thickening, keratinization. Usually treatment of involutional ectropion is by surgery. Cicatricial ectropion that resulted from the scarring of the skin of the lower lid. There is a skin contracture that results in a pull that pulls the eyelid away from the globe, like patient with a burn of the skin of the lower lid or the cheek, trauma, mechanical or chemical injury, ichthyosis. Usually the treatment is by surgery. Third type of ectropion is the paralytic type that resulted from patient with facial nerve palsy, for example, causing retraction of both lids, the upper and lower lid, causing also epiphora, exposure of the cornea, exposure keratopathy. Usually patient with facial palsy, you treat either this patient with temporarily closure of the lid, aiming to protect the cornea, waiting for facial nerve functioning recovery. we use also lubricant to lubricate the cornea, the eye. You use tear substitute at day. At night we use ointment for long-standing effects. Use lid taping at night to close the cornea and protect it from dryness. In addition to lubrication, we use the temporarily measures these, including, as I said, lubrication, or Botox injection into the levator muscle that will result in ptosis to cover the cornea and close the eye. Or the third choice is temporal tarsorrhaphy by suturing both lids laterally, especially in poor Bell's phenomena. The permanent measures for patients with paralytic ectropion, when there is no improvement in the function or recovery in the facial nerve palsy, there's no improvement or there's no recovery of facial nerve palsy after 3 months, usually we will do surgery by reducing the horizontal and vertical dimensions of palpebral aperture. The fourth type of ectropion is mechanical ectropion, caused by tumors on or near the lid margin, any large mass of the lower lid that will pull the lid away and everting it, resulting in a lid eversion by gravity. Treatment is by removing the cause. The congenital type of ectropion, usually rare. In the last slide, we'll see these photos with patients with ectropion. The first one on the left side, the photo of patient with a paralytic ectropion with a facial palsy. As you see here, the patient is incapable of closing the eye. The second photo in the middle, see patient with cicatricial ectropion. It as a result from scarring of the skin in the lower lid, as you see, and treated by removing the scar and using a graft tissue. The third photo, also on the right side, showing surgical treatment of patients with ectropion by shortening the horizontal diameter. These were the most common diseases and abnormalities involving the eyelid discussed in this lecture. Thank you.